Section 1, Introduction to Dysphagia. Hello, my name is Jan Cartwright and today I'll be presenting the dysphagia management for nursing homes. This presentation will be broken into 3 modules: Introduction to Dysphagia, Signs of Dysphagia and Safe Swallowing, and finally, Treatment of Dysphagia. What is dysphagia? Dysphagia is the medical term for difficulty or inability to swallow. Many of our clients within an aged care setting will have a form of dysphagia at some time, whether it be due to difficulty chewing, loss of food or drink from the lips, or more severe forms such as choking or coughing during the meal. For the purpose of this presentation, the swallow is broken into 3 main phases: the oral phase, the pharyngeal phase, and the esophageal phase. A speech pathologist will predominantly manage issues in the oral and pharyngeal phases, whilst the esophageal phase is usually managed by the medical team. The oral phase of the swallow occurs whilst food or drink or a bolus is in a person's mouth. It can be easy to see if there's any problems occurring in this phase. Problems can include parts of a bolus escaping from the nose or escaping from the lips, pocketing in the sides of the cheeks, and slow transit from the front to the back of the mouth. There can also be difficulties in coordination between the oral and the pharyngeal phases, where some of the bolus can fall into the pharynx prior to the next stage of the swallow being triggered. This can cause food or drink to enter the airway before the swallow occurs. The pharyngeal phase begins when the back of the tongue lifts to push the bolus into the pharynx. In this phase, the airway needs to be closed to stop any food or drink going into the airway. Problems in this phase include reduced airway closure and/or food or drink collecting in the pharynx after the swallow is complete. Problems in this phase are harder to see, but can also be more dangerous. The esophageal phase begins when the top of the esophagus opens and ends when the food is in the stomach. Problems in this phase can include poor movement of the bolus to the stomach, reflux, and resulting esophagitis. Types of swallowing in aged care. The 3 most common types of swallowing found in aged care include an elderly swallow, swallowing problems after a stroke, and swallowing problems caused by dementia. A normal elderly swallow is characterised by less coordination, a weaker oral phase, and problems caused by ill-fitting dentures. An elderly person is more likely to tire during eating or drinking, and softer foods are usually indicated. Problems after a stroke. Swallowing problems following a stroke often include one-sided weakness, leading to pocketing of food in one side of the cheek, or loss of bolus from the lips. Other issues include varying levels of consciousness, particularly soon after the stroke. A person who has had a stroke has significant potential to improve their swallow function soon after the incident, and further improvement can be noted up to 3 months. Due to the likelihood of change in swallowing ability, a patient will need regular swallow reviews during this time. Swallowing due to dementia. Problems can include a reduced readiness that eating or drinking is about to occur. This can lead to patients not opening their mouth or not closing their lips over the spoon. Also, they can have a reduced awareness when a bolus is in their mouth, leading to holding. In the early stages of dementia, food or drink with increased texture, taste and smell can help with these issues. During the later stages of dementia, the pharyngeal phase of the swallow is further affected, requiring diet and fluid modifications. Section 2, Signs of Dysphagia and Safe Swallowing. In the second module of the presentation, we will discuss signs of dysphagia and go through safe swallowing procedures. Common signs of dysphagia include difficulty with saliva management, coughing or choking when swallowing liquids or solids, difficulty coordinating swallowing and breathing, feeling of food getting stuck in the throat, food remaining in the mouth after swallowing, frequent throat clearing, prolonged meal times, and unintentional weight loss. You might notice that your patient is becoming fearful during the meal or whilst drinking, starting to refuse intake. Also, any changes in chest condition can indicate dysphagia, such as chest infections or pneumonias. Changes in chest condition can indicate a person is aspirating. Aspiration. An aspiration is when food or drink goes down the wrong way, into the lungs rather than the stomach. Signs of aspiration can include coughing or choking, oxygen desaturations, people becoming out of breath whilst eating or drinking, chest infections, and spikes in temperature. Sometimes people will have chest infections as the only sign, and this is known as silent aspiration. If you suspect your patient has aspirated, please inform the registered nurse for further management. Registered nurses will know the referral process for speech pathology assessments for your facility. Oral hygiene. Maintaining oral hygiene is crucial in the management of persons with dysphagia. Regular denture cleaning, regular dental appointments, watching for signs of decay in teeth and regular mouth care for non-oral clients helps maintain the safety of these clients. A patient that aspirates a small amount of clear fluid whilst having good oral hygiene is much less likely to get an aspiration pneumonia than someone with poor oral hygiene. If you do have a patient who is known aspirator, including the nil by mouth patients, please prioritise their oral hygiene. I am now going to demonstrate some basic safe swallowing procedures. First, the patient needs to be sat upright in their bed or chair to 90 degrees. Lift up the bottom of the bed a little or place pillows under their knees to support their lumbar spine. If you cannot put a person in this position due to pain, support their thoracic spine with extra pillows so their head is in the midline. Also, place further pillows to their side so the patient isn't slumped. Secondly, ensure your patient is alert. If a person cannot open their eyes or follow simple commands, they are unlikely to be able to swallow safely. Orient the person to the meal, allow them to smell and see what is being presented. If needing assistance, please feed from the front, as slow as the person needs. A slight chin tuck is better than a head tipped back. If the person has been assessed by the speech pathologist, please read and follow all recommendations, as they can be quite specific to each client. Finally, try to keep your patient upright for at least 15 minutes after their food or drink. This will minimise the risk of food or drink from entering the airway if it hasn't been adequately pushed into the esophagus, and also reduce the risk of reflux. Section 3, Treatment and Management. Speech pathologists can treat people who have dysphagia in 3 different ways. They can provide exercises to strengthen the muscles of swallowing. They can introduce special movements or change the positioning or posture of people swallowing to maximise safety, and/or they can modify their patient's diet and fluid. For the purpose of this training module, I'll only discuss the final management option: modification of diet and fluids. Speech Pathology Australia and Dietetics Association of Australia together formed a number of standardised diet and fluid terms and descriptions to be used across the board. They identified 4 fluid consistencies and 4 diet consistencies and provided detailed descriptions of what each of these entail. The 4 fluid consistencies. The 4 fluid consistencies include normal fluids, mildly thick fluids, moderately thick fluids, and extremely thick fluids. Each of these has a specific fork test to monitor thickness, so you do not need to rely solely on the recipes attached to the specific brand of thickener. Normal fluids include anything that isn't thickened. Mildly thick or level 150 consistency. Mildly thick or level 150 consistency fluids are described as thicker than naturally thick fluids, such as thick juices, but not as thick as a thick shake. They can be sipped through a straw. The fork test for this fluid is that it flows quickly through a fork but leaves a coating. Moderately thick or level 400 consistency. Moderately thick or level 400 consistency fluids are the consistency of room temperature honey. They can be drunk through a cup but cannot be sipped through a straw. They are a slow flow fluid. The fork test for this fluid is that it dollops from a fork. Extremely thick or level 900 consistency. Extremely thick or level 900 consistency fluids are similar thickness to a mousse or a pudding. They have no flow and have to be spooned into the mouth with a spoon. The fork test for this fluid is that it will sit on the prongs of the fork. The 4 diet consistencies. The 4 food consistencies include normal diet, soft diet, minced moist diet, and puree diet. Some of these consistencies have a fork test attached to them. A normal diet is anything that isn't modified to suit a patient. Soft diet. A soft diet can include naturally soft food such as ripe bananas or food that has been cooked or cut up to get the soft texture. A soft diet can be chewed but does not need to be bitten, and the food can be cut up with the side of a fork. This diet should be moistened with sauces and gravy. It can include white bread with no crusts and soft sandwiches. Minced diet. A minced moist diet can be crushed with a patient's tongue instead of their teeth and should be easily formed into a ball in the mouth. The food should be easily mashed with a fork and can include very soft, moist egg dishes, but no breads. Pureed diet. A pureed diet is smooth and lump-free, but may have a grainy quality. It should be moist and cohesive enough to hold its shape on a spoon. Further information on these diets and fluids are contained within the information pack. Thank you for listening to this presentation. If you'd like any further information, please contact Speech Pathology Australia.